Hypertension or high blood pressure carries an increased risk for early death from stroke, heart attack, heart failure, and kidney failure if it is not detected early and properly controlled. Owing to this, the focus must be on when to initiate treatment rather than how hypertension should be defined. Since there are often no specific symptoms associated with hypertension, there is a need for regular blood pressure screening in the adult population for early detection. In the general adult population, treatment must be initiated at a BP of 140/90 millimeters mercury or higher for adults below 60 years of age, and 115/90 millimeters mercury or higher in those above 60 years. For individuals with diabetes mellitus or non-diabetics with chronic kidney disease, treatment for hypertension must be initiated at a BP of 140/90 millimeters mercury, irrespective of age. In the majority of patients with hypertension, no specific underlying cause is identified. That's primary hypertension. In these individuals, increasing age, family history, excess body weight, lack of physical activity, and excessive alcohol intake may be possible predisposing factors. In about 10% of cases of hypertension, there may be an underlying kidney disease, endocrine disorder, renal artery stenosis, or coarctation of the aorta as secondary hypertension. Once a diagnosis of hypertension is made, the individual should be evaluated to exclude secondary causes and to identify other existing cardiovascular risk factors. For example, diabetes, dyslipidemia, hyperuricemia, among others. Cardiovascular risk factors include age, in men 55 years and above, and in women 65 years and above. Also, family history of premature cardiovascular disease, men aged less than 55 years, and women aged less than 65 years. Dyslipidemia, obesity with a BMI 30 kilograms per meter square and above. Also, diabetes mellitus, smoking, pulse pressure in the elderly 60 millimeters mercury and above. Also, microalbuminuria and also proteinuria, and left ventricular hypertrophy, left bundle branch block, and other electrocardiographic features suggestive of ischemic heart disease. Also, previous stroke or transient ischemic attack, peripheral arterial disease, heart failure, coronary artery disease, chronic kidney disease, and advanced retinopathy, hemorrhages or exudates, and papilledema. Causes: primary hypertension, secondary hypertension, in kidney related conditions like CKD, that's chronic kidney disease, and also polycystic kidney disease. Endocrine causes like pheochromocytoma, Cushing's syndrome, Conn syndrome, hypothyroidism, and acromegaly. And also from vascular conditions like renal artery stenosis and coarctation of the aorta. Symptoms: they are usually none, and occasionally headaches, palpitations, dizziness, easy fatigability. So the signs that are usually elicited are blood pressure 140/90 millimeters mercury or more. So displaced apex beats and signs pointing to a specific cause for secondary hypertension. Investigations: FBC, urinalysis, blood urea, electrolytes and creatinine, blood glucose, serum lipids, serum uric acid, chest X-ray, 12-lead ECG, ultrasound scan of kidneys and adrenals in suspected secondary hypertension, and also echocardiogram. Treatment: the main treatment objectives are to reduce blood pressure levels to recommended targets. For example, less than 140/90 millimeters mercury for age below 60 years, diabetics, and also in CKD. Also less than 150/90 millimeters mercury for age above 60 years. And to manage comorbid conditions, for example, obesity, diabetes, and lipid conditions, and also to prevent cardiovascular, cerebrovascular, and renal complications, to promote therapeutic lifestyle changes, for example, smoking cessation, regular physical activity, and reduction in alcohol intake, and also to identify and manage secondary hypertension appropriately. Non-pharmacological treatment: reduce salt intake, reduce animal fat intake, ensure regular fruit and vegetable intake, weight reduction in obese and overweight individuals, regular exercise, for example, brisk walking for 30 minutes 3 times a week. Also, reduction in alcohol consumption, avoid or quit smoking. Pharmacological treatment: so any of the 5 classes of major antihypertensive drugs can be used as first-line treatment, and they are thiazide diuretics, calcium channel blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and beta blockers. In the general African populations, thiazide diuretics or calcium channel blockers, either as monotherapy or in some combination therapy, is usually preferred. Angiotensin converting enzyme inhibitors are not recommended as first line drugs for uncomplicated hypertension, and dual therapy should be started earlier when the blood pressure exceeds 180/110 millimeters mercury. Additional antihypertensive drugs should be used if target blood pressure levels are not achieved. And add-on drugs should be chosen from first line choices, bearing in mind compelling indications and contraindications. Compelling indications for the choice of antihypertensives: left ventricular hypertrophy, ACE inhibitors or ARBs, CCB, preferably amlodipine, and for microalbuminuria, ACE inhibitors or angiotensin receptor blockers. Renal dysfunction, ACE inhibitors or angiotensin receptor blockers. Caution if the eGFR, estimated glomerular filtration rate, is less than 15 minutes per milliliters without renal replacement therapy. Also, previous stroke, any of the first line drugs, especially ACE inhibitors. Coronary artery disease, angina or myocardial infarction, give ACE inhibitors or angiotensin receptor blockers, beta blockers, and CCBs, as calcium channel blockers. Heart failure, ACE inhibitors, ARBs, cardioselective beta blockers, bisoprolol, metoprolol, carvedilol, loop diuretics, spironolactone in advanced heart failure. Peripheral artery disease, CCB, ACE inhibitors, ARBs. So diabetes mellitus, ACE inhibitors, ARBs. Atrial fibrillation, ARBs, ACE inhibitors, or beta blockers. Compelling contraindications: for gout, thiazide diuretics, beta blockers, asthma, 2 and 3 AV block, and CCB, heart failure, and also ACE inhibitors or ARBs in bilateral renal artery stenosis and hyperkalemia. For treatment of hypertension, first line treatment, you give diuretics, benzoflumetazide, oral 2.5 milligrams daily, or hydrochlorothiazide oral 12.5 milligrams to 25 milligrams daily, or calcium channel blockers, amlodipine oral 5 to 10 milligrams daily, or nifedipine retard oral 10 to 40 milligrams 12 hourly, or angiotensin converting enzyme inhibitors, lisinopril oral 5 to 40 milligrams daily, or ramipril oral 2.5 to 10 milligrams daily, or angiotensin receptor blockers like losartan oral 25 to 100 milligrams daily, or candesartan oral 4 to 32 milligrams daily, or valsartan oral 80 to 160 milligrams daily, or beta blockers atenolol oral 50 to 100 milligrams daily, or bisoprolol oral 5 to 20 milligrams daily, or metoprolol oral 50 to 200 milligrams 12 hourly, or carvedilol oral 12.5 to 50 milligrams daily, or labetalol oral 100 to 400 milligrams 12 hourly. Second line treatments, give centrally acting agents like metaldopa oral 250 milligrams 1 gram, 250 milligrams to 1 gram 8 to 12 hourly, or vasodilators hydralazine oral 25 to 50 milligrams 12 hourly, or alpha blockers prazosin oral 0.5 milligrams 8 to 12 hourly, and increasing gradually to a maximum dose of 20 milligrams, or aldosterone antagonists spironolactone oral 25 to 50 milligrams daily. Referral criteria. So refer the following categories of hypertensive patients to an appropriate specialist. So those not achieving the target blood pressure level after several months of treatment, and those on 3 or more antihypertensive drugs yet have poor BP control, and those with worsening of BP over a few weeks or months, and those with plasma creatinine levels above the upper limits of normal, and also those with diabetes mellitus, those with multiple risk factors like diabetes, dyslipidemia, obesity, family history of heart disease. Also those on not on diuretics but have persistently low potassium on repeated blood tests, and all children, young adults, and pregnant women with elevated BP. Let's look at the flow chart. So patients presenting with hypertension, you assess BP level plus other cardiovascular risk factors. For low risk, lifestyle modification for 6 to 12 months. If the systolic blood pressure is less than 140 millimeters mercury, or diastolic blood pressure is less than 90 millimeters mercury, lifestyle modifications plus monitoring of BP regularly is required. And if the systolic blood pressure is more than 140 millimeters mercury, or diastolic blood pressure is more than 90 millimeters mercury, lifestyle modifications plus drug treatments are required. Also, for moderate risk, lifestyle modifications for 3 to 6 months. If systolic blood pressure is less than 140 millimeters mercury, or diastolic blood pressure is less than 90 millimeters mercury, lifestyle modification and monitoring of BP regularly are required. And if systolic blood pressure is more than 140 millimeters mercury, or diastolic blood pressure is more than 90 millimeters mercury, then lifestyle modifications plus drug treatments are required. For high risk, lifestyle modifications plus drug treatments.